My name is Steve Kane, and I'm a cornea specialist in the Clearwater area. I've been practicing there for about 2.5 years now, and it's a lot of high-volume, complex cornea that I do. I discovered mechanical dry eye a few years ago. I had a very elderly patient, he's in his 90s, had already been treated for dry eye by multiple cornea specialists and did have staining as well as symptoms of dry eye complaints, just chronic burning and irritation. And I noticed when I was examining him that his conjunctiva actually was interrupting his tear film, and he wasn't getting a good spread of his tear film when he was blinking. And so I talked to him about treating the redundancy of the conjunctiva with trying basically to treat the mechanical dry eye, recreating the inferior fornix and using amniotic membrane tissue to redistribute the tear film and recreate a nice healthy tear pool for his eye. He went through with the surgery, which just takes a few minutes. Can do it under a block. I use a little bit of Tissile glue, and I kind of tuck the tissue down into the fornix so that you get a nice recreation of the normal architecture. And it treats so many issues at the same time. So a lot of discomfort he was having from having the redundant conjunctiva kind of overlapping his lid margin, as well as the dry eye symptoms and the signs that I could see on exam, they all improved after I did that surgery. So that was when I discovered it. So I take a very stepwise approach to treating dry eye. I think a lot of patients, especially elderly patients, have some deficiency in their lacrimal system, be it aqueous deficient, be it oil deficient, meibomian gland disease, the mechanical dry eye component. There's usually a multifactorial thing going on. So I start with the low-hanging fruit, which would be things like nutraceuticals, omega-6s, omega-3s, artificial tears, ointments, compresses, and kind of have a food chain ladder approach to augmenting my treatment based on how they respond. And some patients, lubricating tears and compresses is enough to, eyelid margin treatments. But a lot of patients need something else. And what that something else is, I take a very tailored approach. So based on the exam findings, if I see mechanical dry eye, then I'm going to try to treat that after I've done the easy things and the patient still isn't any better and they still have the findings of dry eye, then I'm going to move on to treating other causes. I think this mechanical dry eye is something that's very commonly overlooked, and I think true for anything in medicine. If you don't look for it, you won't see it, you won't find it. And I think it's much more common than people understand. I think every ophthalmologist has dry eye patients that they feel like they've thrown the book at, and the patient keeps coming back miserable. And I would challenge my colleagues to really look for the mechanical dry eye and offer the treatment for those patients who are symptomatic and who also have obvious, like I said, one of my thresholds is the conjunctiva interrupting the tear film. And in symptomatic patients with that finding, I think mechanical treatments of a mechanical problem just makes sense. So I would encourage them to look for it, and if they look for it, they're probably going to discover it in a lot more patients than they realize.